presentation will come. I think you should be on there. Yeah, it's on air. Just start speaking, I think.
Or you are the only viewer, is it?
No, there will be others viewing.
Today we have a presentation on biliary atresia titled From Despondency to Hope. Biliary atresia is a difficult disease to treat. And with the advent of liver transplantation, the outcomes for children with biliary atresia has changed dramatically in the presentation. I'll see it in what view. So in this presentation, we will have a brief overview of biliary atresia. We will discuss the specific issues that impact the results of our treatment, which are frequently asked questions, and make the arguments for sequential liver transplantation and look at the results that we can produce today. This is a child who is about 15 years old now, and she had a Kasai Potentrost a long time ago. You can make out that she has done very well. She has attained puberty, and she goes to a regular school and has good ranking. She is a success case. There are very few of such cases that we see in our practice, and that's why we were moved on to try and find a solution for this problem by starting pediatric liver transplantation. As you well know, it is a unique disease. There are two forms, embryonal and postnatal. The embryonal generally has coexisting malformations and has a poorer result. The postnatal form appears a little later. The children are more robust, and they do much better if a potonephrostomy is done at the appropriate time. The incidence is about 1 in 8,000. We must remember it's a pan-biliary disease. It's an inflammatory process that is continuous and destructive. Its cause is unknown, but we believe it's an immunological process mainly.
I want to see the video.
Yeah.
No, don't go to the full screen. It is not functioning when you go to full screen.
Can I have to see it on this?
Yeah, no, you will have to do it from here only, I think.
Sure,
I mean, just start with this one again.
This one?
Yeah.
This one?
Yeah.
Shall I start? Yeah, we will start with this example of this young case who was almost 15 years after a Kasai enterostomy. As you can see, she is doing well, and she is now attained puberty, very good growth, and is doing very well in school. This is not the case in the majority of cases, and our experience has been only a third or a little more do well with the Kasai enterostomy. And therefore, we embarked on developing a pediatric liver transplantation program. As you know, it's a unique disease. There are two forms, the embryonal or the fetal form and the postnatal form. The former is a rather poor form of the disease in the sense that 20 to 35% have coexisting malformations and they do not do well with the autoenterostomy. The latter, the babies are very robust, they do well, and with an operation done at the appropriate time, you would expect a good result. The incidence in our country is not very clearly defined, but this is what is quoted. It's a pan-biliary disease with progressive inflammation of the bile ducts, with fibrosis and obliteration of the whole tree. Unknown, the etiology is unknown. The immunological basis is thought of the most attractive at present. Untreated, the survival in biliary atresia is about 12 to 19 months. I do not think that the whole presentation of the classification is important. It is important to know that the more common type is this type where the distal ducts are patent and all the proximal ducts are obliterated. And very rarely you get the so-called cystic form of the disease. But one must remember that all of them are treated the same way with the Kasai enterostomy. The terminology of correctable type of biliary atresia, I think, is wrong and should not be used. It's to remind everyone that this is a pan-biliary disease which is progressive. There's a special group of this condition where you have paucity of intrahepatic bile ducts, and the ratio there will be less than 0.5 ducts for the number of portal tracts that are examined on a biopsy. And you could see this in the picture above, where the ducts inside the liver are almost sparse, even though you can see some ductal outline outside the liver. And this is very classical of paucity syndromes, and they can be either syndromic or non-syndromic. It's essential to have an early diagnosis, so any jaundice beyond 14 days should be investigated. If the conjugated bilirubin is more than 2 milligrams per deciliter, we should begin workup. In our experience over the years of treating these patients, we have found that ultrasound, liver biopsy, a HIDA scan are helpful, but they are never conclusively diagnostic. And you're always left wondering whether is there anything more to do. So the gold standard, we believe, is still an operative cholangiogram and a core biopsy, which of course the result will be available to you later to prognosticate how well this child will do. The Kasai enterostomy is the standard operation that we perform, but just to mention that some attention to the ducts in this corner of the portal tract, or at least in the ductal plate that we dissect out after slooping the vessels, is important, to go as laterally as possible and sometimes over the branch vessels so that you get all the ducts into the anastomosis. A standard Roux-en-Y anastomosis is performed, and reconstitution of the intestinal tract, of course, performed. In this illustration of operative pictures, I would like to stress on the last frame where you could see after you do the dissection, you should get some good bile drainage. And this is after performing the Roux-loop. You could come back to the portal area and there you would see bile collect. You have to differentiate between lymphatic fluid and bile fluid. The bile fluid tends to be a little more oily and soapy, whereas lymphatic fluid obviously is more watery. So there is a way to know if this is good bile draining. The natural history of the disease, if the baby is not treated, survival beyond 2 years is not known, at least very poor. Cirrhosis due to cholestasis and subsequent clinical decompensation is evident as early as 4 to 6 months. And in a Kasai enterostomy might benefit these children, about 60% of affected infants. from various long-term follow-ups, the results are not as good. Over a long period of time, now that the operation is more than 50 years old, only 10% will probably survive with their native livers. This is the illustration from this article from the Lancet, which shows that without rescue of liver transplantation, almost half of them are dead by about 2 years. Patients without a Kasai procedure and a failed Kasai operation will need a liver transplantation by 1 year, so that, at least according to these authors, because it tends to have a better result, because waiting for them to decompensate and get in very poor health is only going to make the operation difficult and probably post-operative course even more difficult in these transplanted babies. Role in Kasai, we need optical angiography and liver biopsy, and identifying correctable conditions that like biliary atresia, choledochosis, and bile duct perforation. The main advantages are significant number of children have a long-term survival. It probably prevents list and defers the need for transplantation. These are some outcomes, published outcomes, and with native liver survival, results have been published from various centers. But all these studies are based on very early experience, and later on I will demonstrate how, with improving experience with the Kasai operation, results can be even better. This is the 20-year survival of Kasai portal enterostomy in 3 groups of patients, early, and this is the early period where the survival was not as good. During a later term, almost 58% survival was achieved. So with experience and with more operations being performed, one will tend to get better, making an argument for why it should be concentrated in any one particular center. That's later. Having established that it is a good procedure, what are the issues related to the operation and the issues related to the post-operative care? These are the main things that are under consideration: the age of portal enterostomy, the degree of fibrosis, the size of the ducts at the porta, the presence or absence of coexisting anomalies, and the surgical experience of the team. Age, as we all know, the sooner you do it, the better. But there's a critical period that is beneficial for this. Late operations after 100 days are usually not successful, although there are published data that people achieve up to 25 to 35% successful bile drainage. But that does not mean that's cure. It probably is just bile drainage. When not to proceed with the Kasai portal enterostomy, the results are better less than 60 days. However, reports of reasonable outcomes, as I mentioned, are good after 100 days. Therefore, age alone is not the only reliable parameter. Other parameters like established cirrhosis on pathology or operative cholangiography at the time of surgery, established features of portal hypertension, and prolonged INR unresponsive to vitamin K, and the presence of biliary atresia, splenic malformation as referred to, these are the ones that do not do well and perhaps may not benefit from a Kasai post-portal enterostomy. Remember that the portal enterostomy is a treatment for biliary atresia and not cirrhosis or portal hypertension. One could have fairly high degree of mortality when doing these procedures in children with established cirrhosis, and even an operative cholangiogram could have a very high degree of mortality. So one needs to be careful about attempting these procedures when established cirrhosis or portal hypertension is present. Is there a role for reoperation after Kasai procedure in patients who stop draining bile? We do not think so. We have attempted it and have failed uniformly in most cases. Does the degree of fibrosis and the size of bile ducts on the porta hepatis at the time of Kasai influence the outcome? A study was done by one of my colleagues, Dr. Kanishka Das, where we looked at about 114 cases and did a clinico-pathological correlation and did not find any significance in the liver histology as a whole between the two outcome groups, or we didn't find a significant correlation between liver histology, that is the total pathological score, and the clinical outcome in those groups. So we did not feel that that influenced it to that degree. Coexisting malformations definitely impact on the results of Kasai porta enterostomy. As we mentioned earlier, we have various conditions that might cause a poor outcome. Do centralizing of services help? Yes, this has been the policy in the United Kingdom, where now over the last, probably starting from the early 2000s, all Kasai operations are concentrated in 2 or 3 centers. I think it's now 3, where the results have definitely improved with the expertise available in each of these centers. In our country, it might be very difficult to do because we have great distances, and it probably is unreasonable to expect. We may have to create regions of interest for Kasai porta enterostomy in various parts of the country. The postoperative care is very standard. We need to prevent cholangitis, improve the nutrition, and the use of steroids and UDCA. This is our protocol as shown down here. We will continue antibiotic prophylaxis for 1 year and insist on good nutrition and support if necessary. We'll even force feed if necessary. However, there is no clear evidence that steroids help clear jaundice by 6 months or defer liver transplantation. This is in a sort of study of or a meta-analysis of many studies, and they did not find evidence enough to support that steroids were really beneficial. Most centers will still continue to use steroids, antibiotics, and UDCA. In a personal series now, over 156 cases, 25% are jaundice-free at last follow-up, 40% are alive with their native livers. Over 100 days, and when we had embarked on the operation, it failed. Is the procedure relevant today? Yes, we think so, because many centers with experience have shown very good improvement. 80% of these may go on to adolescents without liver transplantation. Others have called it a palliative operation till rescued by liver transplant is the preferred primary treatment. Suggest a liver transplantation. As you see, survival after Kasai, within about 50 days, you will expect child range to take place and the child. But if you do not get the bilirubin dropping to less than 2, you can see that most of them do very poorly. Bilirubin less than 2 do very well. Similarly, here you can see the Kasai survivals after a porta enterostomy, with those operated at more than 100 days, between 30 and 80 days, and less than 30 days. And it's interesting to note that those operated very early, that is less than 30 days, fare as poorly as those operated very late. So maybe there's an ideal time between 70 days, 60 and 70 days, best time to undertake a porta enterostomy. So these results just point to that observation. Fibrosis in this particular study did not show very much difference, significant difference between those with, but survival for those without or less fibrosis was a little better. Indications: primary failure of Kasai porta enterostomy, recurrent cholangitis, progressive cirrhosis, symptomatic portal hypertension, hepatopulmonary syndrome. These would be definite indications for referring early. Delayed prognosis and referral, no Kasai porta enterostomy, and primary liver transplant is a possibility. So is it? I think in those cases where we mentioned earlier, where late, presenting with cirrhosis, portal hypertension, and or pulmonary changes, definitely it might be the first thing to do. But Kasai still remains the first operation of choice. Transplantation, as you know, is a very, very formidable undertaking. And if you can get up to, as is quoted in more recent studies, of native liver survival, then that should continue to be the first operation that is offered. Graft survival with or without portoenterostomy, the question is often asked, does a portoenterostomy impact or vitiate the outcome of liver transplantation? This study that with or without a portoenterostomy, liver transplantation are almost the same. That doing a Kasai is going to in any way affect the outcome for liver transplantation. So the take-home messages would be to a good outcome is expected if there's an early referral. The portoenterostomy is followed by liver transplantation is the best option today. The portoenterostomy can be potentially deliver excellent outcomes, prolong survival with native liver, and delay the need for liver transplantation to those who do not drain bile or drain bile and then stop after some time. The previous portoenterostomy can increase the complexity of the operation, but it does not affect the overall outcome. To identify unsuccessful Kasai early and refer for liver transplant is the best option, as they carry an 80% chance of death in the first year. We have had children who are waiting on the waiting list for a liver transplantation who have died with complications like sepsis, cholangitis, or even bleeds. So in conclusion, biliary atresia is now a treatable condition with up to 90% of infants expected to survive in centers offering portoenterostomy followed by a liver transplantation. Thank you. So there are questions now open to discussion. I can't see the questions though. Oh, you ahead. No, but what about the transmit?
What we could see is okay. I think it depends upon.
Who's are you still online?
Yeah.
This was a test presentation that we just put together. The main idea is to see if it transmits properly, and if we could have two-way connection with the audience. The disadvantage here, as we see, is we can't see the audience, but we assume there will be others who can access this sort of webinar and be able to participate. Okay. How are they supposed to send back questions? I'll check this. Where did you stop? You